everyone, and thanks so much for joining us in this last CanHepC session of the day. We always save the best for last, but I'm slightly biased. So this is the Prevention and Priority Population session. We've got a great lineup of speakers, so thanks again for joining us. I'd like to start off by asking Daniel Alakpa, who is a CanHepC trainee and completing his PhD with Guillaume Fontaine at McGill, who will introduce our keynote speaker.
I would like to introduce Dr. Julie Bruneau, who holds the Canada Research Chair in Addiction Medicine. She is a professor in the Department of Family and Emergency Medicine at the Université de Montréal and a senior clinical scientist at the Centre Hospitalier de l'Université de Montréal, the CHUM Research Center. Dr. Bruneau's work centers on advancing best practices to enhance addiction care, well-being, and prevent harms, including HIV, HCV, among people who use drugs. Please welcome her.
Quel honneur.
Merci beaucoup, Daniel. Bonjour tout le monde. Merci d'être là à cette heure. Thank you so much to be here. Today I'm going to talk about successes and failures of HCV prevention among people who use or inject drugs in Canada. And it has been a very interesting topic to try to find ways to tell that story. But I'm always so interested in prevention that it's good. So first, I want to acknowledge the land we're meeting is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home of many diverse First Nations, Inuit, and Métis people. I also work and play in Jungjagi, Montreal, which is the unceded territories of the Kaningiahaga people. And I'm very humble, and I think it's very important to reaffirm our commitment to actively contributing to reconciliations. And this is important to talk about this because Indigenous peoples are disproportionately affected by HCV, by new HCV transmission as well, and they are part of the key but unserved and not so well served populations. So these are my disclosures. So I said successes and failures, but actually I'm going to reframe this as success opportunities, failures challenges, because I think we have to be into the impact framework. This is the same slide you've seen this morning. Maybe we have the tools to eliminate HCV in Canada among people who inject drugs. We have the prevention strategies, and I'll certainly talk more about this. Simple diagnostic, effective treatment. Whether or not we use these properly and scale up properly is another story that we'll kind of go through now. So what do we know about current HCV transmission in Canada among people who use drugs? I say use or inject because a lot of people have injected, are not injecting anymore, may go back to injection, and I think it's much more important to think about that, the people, than the behavior themselves. So this is a line of treatment and a line of new infections. And basically what we're seeing is, obviously we have a jump of treatment in Canada, and then we have treatment that is slowly going down. We still seem to have treatment a bit more than new infection, but basically what we're seeing is that the new infections stalled at 8,000 a year in Canada, despite all this treatment. It's not equal of each provinces. When we're looking at the reported cases, the rate per 100,000 people, you see that we go from about 10 to 38 in Saskatchewan and 43 in Manitoba. So we have very diverse. And remembering that the WHO target is less than 5 in that strata. 71% of cases are actually in BC, Ontario, and Quebec, which is the three big provinces. So transmission is concentrated among people who inject drugs. This is why when we're talking about prevention, we're talking mostly of that population. On conservative estimates, 60, probably around 80% of all the new cases in Canada are among that population. And this paper from Adelina Artini in the multi-country studies using estimates also looked at Canada, as you see, post-DAA HCV incidence was estimated at 9.6 and pre-DAA was 11.3, which is not very significant, which is also coinciding to what we've seen in the general population. So estimate now, we're seeing the incidence in people who inject drugs, but it doesn't give us an idea of how many people. And actually, Nashira Popovic and her group at PHAC just published the latest population size estimates of people who inject drugs in Canada, which is around 100,000, but also 400,000 more or less that have ever injected. And these estimates, while very robust with the method, are limited by the type of data that we can use to get those estimates. And this is something that I'm coming back to it. Now, I'm going to talk about people who inject drugs, but people who inject drugs is not kind of a bubble within Canada. And when we're thinking about key population or population that we have to think it through when we're thinking of elimination, obviously there is more, a bigger proportion of people who inject drugs that are represented in incarcerated population. Indigenous populations are more affected by HCV. They're also more likely to be incarcerated. So there is a mixture of profiles of people that just encompass a lot of other issues than just people who inject drugs when we're thinking about transmission. So evidence-based approaches, probably most of you or many of you were this morning in this fantastic session with Natasha and Jason Grebley. So I will go very quick saying basically to prevent HCV among people who inject drugs, there is the big three: needle syringe programs, OAT, and HCV treatment as prevention. So needle syringe program, mixed results, mixed impact, but on the protective side, OAT, 50% reduction, mixing needle syringe and OAT, 71% reduction in HCV risk. HCV treatment as prevention, as we've seen this morning, coupled with harm reduction is better, and the quicker we treat the high-risk population, the better. That was quick. We also have real data to look into this, and I took the example of Tayside in the UK, where they integrated a coordinate effort of many types of intervention for prevention, test, and treat in that population. And what they've looked into the right side of the slide is basically that compared to other regions in UK, they have achieved a reduction, absolute and in percentage, of the number of HCV prevalence in their population. So not only modeling, but also real data that says that it works. Now, current HCV prevention landscape in Canada, I think we have to go beyond the big three. And the first thing I wanted to say that most of the studies that I've shown, not Tayside, but the modeling, the OAT, the NSP, are based on data that were dated prior 2016. In Canada, obviously we have COVID, we have the Canada opioid crisis, But under the surface, a lot of things have changed in our structural society, I say. Housing affordability, inequalities, big changes in drug supplies in all parts of the country, societal and internalized stigma, and also the fragilization, I don't know if it's a word, but en français it works, of the healthcare systems and the mental health and addiction systems. So lots have changed, and this morning we've heard about harm reduction as well. So increased fentanyl, of course, but I just want to point out methamphetamine as well has been a huge, particularly in the East. It was a West problem. Now it's more of an Eastern problem as well. We had cocaine before. We probably preferred cocaine than the methamphetamine when it comes to harms. And then we also have, and it's very important, very big changes in the type of drug use that people are doing, with a lot of combinations, a lot of toxic, wanted and unwanted combinations, and which are associated with the death as well. So how do we fare with harm reduction? And for those who were in the panel, we know that we're going backwards a bit. But in 2016, Brendan Jacka did this work with Jason Grebley and myself on trying to evaluate or estimate the coverage of OAT and NSP. And at the time, we were already meeting some of the WHO at the time targets anyway. Of course, again, we had to use indirect multipliers methods, extrapolation base of OAT. So there's a lot of limitations in these numbers, but we were fairly good. And you've seen this morning as well that Canada is up there in that corner where we're supposed to be good in coverage. Now, we also know that there is a lot of limitations. This is average. This is based on the 3 big province best numbers. So we have, it depends on supply volume. We've seen that even in the big cities, we see cut down in the number of syringes, geographic accessibility, also adequacy and availability of all injection equipment and non-injection for the use of non-injection drugs, and co-location of services and integration of services. So there is a lot of prevention challenges in our needle syringe programs. OAT evolutions. OAT is one of the most effective primary prevention intervention. It's been evaluated before, and in general, within more stringent OAT programs that we have post-COVID. Post-COVID, we had increased take-homes, reduced requirements for in-person, more flexible pharmacy, expanded telemedicine prescribing. And this is good because we improved the treatment continuity, we improved some retention, but what it did do to the OAT structure and whether or not it has changed the effect of OAT protection, this is something we really don't know. And the prevention failure here is that we still don't have effective pharmacological treatment for stimulant use disorder. And in Montreal, cocaine was always a big determinant of HCV incidence, for instance. So now I have to speak about safer supply or agonist treatment with alternative medication, because I think this is one of the changes in OAT in a small proportion of people in big centers in general, but it was really a movement from the community and from the physicians to save lives with the toxic fentanyl supply. And Canada is well positioned to become an international leader in developing new models of OAT, and it's a progressive way of seeing it. But we need to generate evidence. We have some evidence and some positive signals of reduction of mortality and certainly high acceptability in the community of these programs. But there is also concerns about diversion, other adverse effects, initiation of opioids with those medications that we cannot just see. But one of the things that I want to just point out is we don't know what it does to the effect of HCV transmission with these new type of programs where people are much more tolerated when they continue to inject and the retention's better, but maybe this is something that we also have to consider when we are looking at HCV incidence. So it's an opportunity and also a challenge. Now, we also have had an expansion of supervised consumption sites across Canada, as you see here. And this is something is also helping linkage to care, helping retention, helping education, but we don't have any data on what it does to HCV prevention. And this is something that we should do. Of course, there is prevention challenges, cuts in budgets for the supply in needle syringe programs, but also a political backlash in harm reduction, supervised consumption sites, and we heard this morning also needle syringe program 121 in some provinces. It's in Alberta, it's also here in Ontario, and in Quebec we had this not in my backyard also beginning to see. So we are still a progressive country with a lot of harm reduction based on evidence, but we also have our caveats and our challenges. Now, prevention, when we thinking about treatment as prevention. So we have access to models of care to increase test and treat for people who use drugs across the countries. Wonderful models, as you see here, housing, outreach, peers. There's a lot of things that is going on, and I'll just give you a few examples like Kool-Aid in Victoria, ACE teams in Edmonton, the pharmacy, nurse-led housing, also community pop-up clinics in Vancouver and mobile outreach in the Atlantic provinces. Some very nice telemedicine programs in Alberta and also in Listigouche in Quebec and up north in Quebec to serve the community, the indigenous communities, Inuit in general in Quebec, and some other programs of point of care that are also emerging. Some provinces like Ontario have thought of provincial programs for test and treat as well. But in the end, we don't have a clear picture or a coordinated mapping of what's going on. And most of these programs are relatively small and they're not scaled up as they should. So last and not least, vaccine. I won't talk too much because CanHepC and we have a whole session tomorrow, but I certainly want to just highlight that with everything I've said, vaccine is certainly necessary even in countries like Canada, even if we have good harm reduction and treatment, because we still have incidents and people who inject drugs and other people at risk. So I'll just give, what I've been showing is kind of big data, but now I took some observational data, mostly from Montreal, to see what's going on from the COVID. And the track surveys, as you know, is a national cross-sectional in several sentinel sites, mostly harm reduction. The last phase was published on data from 2017 and 2019. And of course, there is a bit of a bias because it's harm reduction, but the majority of people have been tested at least once in their life. 64% were antibody HCV positive, 37% were RNA positive, with half of them knowing their status. Of those, about half were linked to treatment, and only 14% were treated. And it's, as I said, 2017, 2019, so keep it in mind. And the coverage for OAT and NSP in that population was pretty good. but the risks were also, the behaviors were still, and particularly with non-injectable paraphernalia material. So I think the idea of the injection itself is something, but all the protocols of injection is something that is less. So when we're looking at our cohort in Montreal, as you know, it's a long-standing cohort. We're following people every 3 months. We had to rebuild quite the cohort after the COVID, we have to say. So this is the 546 people that we've seen between November 2022 and June 2025, mean age 41, mostly men, 5% self-identified as Indigenous. And what you see is basically a bit the same as what you were seeing before in the Sentinel. So about 50% on OAT, 93% got their syringes in safe sources, which mean needle syringe program, or pharmacies in Montreal, which is a big network. People were reporting 12% shared needle syringes and 42% injected in SIS. So in Montreal, it's a wonderful city. And Montreal has quite a good network of primary care physicians, particularly in the downtown site, and addiction centers and people caring for people who inject drugs. So if you want a treatment for Hep C, you can get it relatively simply and without waiting. And people will, and if the physician or the nurse asks for the medication at the RAM queue, it's going to be an immediate approval. So it's pretty good. We don't have a lot of point of care testing and treatment. That's another story. But just to give you, so this is in our cohort, the annual incidence of HCV from 2011. So you see that we had a curve that were going down. 2020, 2021, you discard those numbers because it was basically down, the cohort. But what we see at what we began to reaccrue people, and again, it has to take to very cautiously because the one that we reaccrue are a combination of old participants and new participants, but mostly the same age. And what you see here, and you see an increase in the HCV incidence in that cohort. So there's certainly a warning there. If there might be some bias. And I also, and thanks to Karine Blouin for the PWUD, which is the Sentinel of Quebec, we've looked at among those who were HCV antibody positive, what was the proportion of those who were still RNA positive. So in our cohort, where we have active linkage to care, it was 24%, and in the PWUD, it was 33%. So it's clear that we're treating. And we're treating at a level, I was talking to Jason, that is not so far from what they see in sites in Australia. So we're treating, we have harm reduction, but we still have high incidence, so we have to understand what we have to do more. This has kept a bit, but this was saying that basically we don't see a difference now by OAT of initiation to treatment. So you don't have to be on OAT anymore in Montreal to be treated for HCV. And when we were looking at this mathematical modeling from Marina Klein's group, what we see is they basically say what we see is that even if we scale up more needle syringe or OAT, it won't make so much different. But after elimination, sustained harm reduction is needed. So what works in prison? So I talked about the priority population, and I just want to highlight that, of course, there is the PWUD study in Australia where it was really shown that point of care testing improves time to treatment initiation. And then Nadine here did this study in provincial prisons beyond prison walls, where she showed that with the opt-out testing, if you really care about how you link to treatment after prison, because people stay not very long in provincial prison, then it's increased the linkage to care and the treatment. This Canadian survey shows that actually it was a bit discouraging for many years, but now we see that there is improvement in HCV care in the provincial and territorial prisons in Canada in the past 4 years, with increased availability of DAA, but few offer opt-out screening, probably not so much of point of care. Increased availability of OAT, but still no NSP. And then actually a lot of healthcare providers within the prison don't really know what's available. So they could do it, but they don't do it because they don't know. I certainly want to also emphasize the structural harms embodied by Indigenous people who inject drugs in Canada. There's lots of differences in risk, access, uptakes, outcomes that it demands culturally safe services. Indigenicity, culture stigma, and structural inequity shape both the risk and also the service engagement. And it's a call for Indigenous leaderships and also the data sovereignty that matter to make sure that the community are on board and are leading their own responses. So in summary, Canada has effective treatment needle syringe programs, evolving opiate agonist therapy, novel harm reductions, including supervised consumption sites. It has tons of creative, innovative models of care throughout the country, adapted to local needs, etc. But we're kind of stuck because we're not into the path of elimination. Maybe we are, but 2 years ago it didn't show. So I like to see it as we have all the pieces of the puzzles, but they're not put together in a way that makes sense and is efficient, and there is return of impact and on the investment we're making. CanHepC has done this amazing work of doing the blueprint and now the roadmaps, and I think these are really good tools to begin to think of something that would look much more like this one, which would be, of course, a multi-pronged approach adapted to needs that encompass harm reduction treatment, integrated models of care, but certainly implementation and scale-up that is informed by the roadmaps, by the communities, and political leadership and political will, which is underlying everything. And we also need evaluation of impact that implies population-level measures accessing the heterogeneity and all the data that are sitting in our provinces and territories, the measures and indicators at the level of the population at risk, the cohorts, the cross-sectional studies, the monitoring that is happening in communities, and also knowing better with the denominator of our prevention, harm reduction, and treatment gaps across the country to build evidence with real-time monitoring. And I want to thank you. And thanks, of course, Nana, who helped me a lot with this presentation, and Yvette, who is also always there to help, and all the teams and my family. Thank you.
Thank you, Julie, for this very comprehensive presentation. We'll open the floor up now to questions. We have about 10 minutes.
So great talk as always, Julie. Jason Grebley from the Kirby Institute. One thing that sort of struck me, and Adelina Artini did this really nice systematic review looking at the impact of houselessness on HCV incidence, and I also saw that was associated with incident hepatitis C in the HepCo cohort. I'm just curious on your thoughts around where we should go with this in terms of further work around houselessness. Has there been progress? It seems to be at the crux of the discussions that we're having in this space, and I'm just wondering if you have any thoughts on ways forward. Do we need to be working more closely with our colleagues that are doing work in houselessness around interventions that work? Because this seems so critical to addressing the issue. What are your thoughts about that?
I think housing is actually in Canada a priority. Mark Carney has spoken about housing. There is a lot of people speaking. The big cities are really concerned with all the camps and everything, even the smaller cities. So I think it's a good opportunity when you're talking about syndemics. I don't think that we should tackle housing as HCV elimination and try to do it ourselves. But we should to bring in the mix the HCV with the housing and working with people with housing and make sure that all the people that are working, and there is money into this housing business, we should be able to put HCV outcome in their package of indicators and how we go. And obviously, this speaks to the syndemic of what's happening with people who inject drugs and people who use drugs in general. And it's housing, it's stigma, it's geographical inequalities and everything. But yes, housing is probably a good opportunity to do something. But it's broader than just trying this, I think. Hi, Sam.
Thank you. Very nice presentation. I'm wondering what, I mean, obviously you've got this great multidisciplinary team and clinic. How do you keep this, I got to use the correct word here, underserved priority population engaged? I mean, do you offer incentives, or if so, what,
you mean
what's
in the cohort or in general?
Or
I think
both, yeah.
I think it's a mixture of things, but talking from my clinical and epidemiological perspective, first of all, we have people with lived and living experience in our own team, and actually one is now leading as a first author a paper where she's looked at different ways of engaging and recruiting people and keeping them engaged, and it's really interesting to see that work. The second thing is we need to adapt to what they want to come. And one of the things, while working with communities in the past few years with Montréal Sans Hepatitis, that we realized that in Montreal we have a lot of primary care HCV treatment. And primary care or addiction treatment, they offer lots of services encompassing a lot of social services, help, etc. We have a small population of people that never want to be treated. And one of the reasons why is that they just want to be treated for their HCV and they don't really want the other package of the services. So this is something that we're going to offer now. So I think we have to diversify and understand while going forward, what are the changes in the type of services that we offer, and being very dynamic.
Thanks, Julie, for a beautiful presentation. So I don't want this to be a negative question, but I have a question about the OAT and NSP data that we cite all the time about the 71% risk reduction. And I know that that's sort of meta-analyzed data from lots of studies that are pulled together. The estimates are fairly wide when you look at the individual studies. And one question I have is about the follow-up time and whether, and I'm highlighting this because of the drop in NSP coverage that we've seen recently in some settings, is whether people maintain, like whether that risk reduction is maintained, because someone, as long as they're using NSP, they're their risk is reduced. But if they have periods where they're not using NSP, then they have a risk of infection. And I guess I'm just wondering, when you look at those individual studies, what is the time frame of looking at incidence, and is it maintained over time?
I don't think that when you were looking, I was part of these meta-analysis, and I don't think the answer is in those studies that we can look, because they kind of aggregated many studies. Our study was in it, and there was differences. And actually, for needle syringe programs, just when you go to granular, in Europe, it was really good, relatively sustained. I mean, the point estimates were the same, all protective. North America, not so much, and it was interpreted as we're more cocaine / opioids than just opioids, and that was one of the reasons why. But when you look at those aggregates things, they were, I think my main point is that they were way before the fentanyl crisis. Opioid agonist therapy with fentanyl is not the same animal as opioid agonist therapy with heroin and the other opioids. So my point is we should take a step back and maybe reassess and put in the mix the supervised consumption sites, put in the mix all these other things to reassess what we really need to improve HCV prevention, aside from the big three that I was saying. I think we have to acknowledge that we're not in the same world as we were before, and I would suspect that we would see different effect of OAT, given that people on OAT are more at risk now than they were when you had to go with your methadone every day at the pharmacy, and if you didn't go for 3 days, you were cut by half, and then you were out of the program. So I think it's a bit of an ideal situation before, and this is why I would call for new data.
Thanks.
Maybe, Julie, I have a question for you. You've led HEPCO for over 20 years now. Over 20 years. And assuming the cohort has aged over time, and curious, who is contributing to hepatitis C incidence in that cohort? Is it the long-standing people who injected drugs?
Yeah.
Or are they the new injectors?
Oh, we've demonstrated this very well with HIV, but we also look into it with HCV. And in general, the new primary infection occurs really early on the follow-up. Reinfection is a different thing, because you have people who reinfect 2 or 3 times and they get retreated. I haven't shown it here, but our reinfection rate is about the same as the primary infection rate in that cohort. You've seen that they were, the good thing, not the good thing, but one of the things that happened with COVID is that a part of the cohort have been renewed in a way, because we've lost people during the COVID. Some were dead, but also some were gone. So it's interesting to see that the new recruits in the cohort are not like they were 20 years ago, 30 years old. The new recruits of people who are injecting drug but were not in the cohort are 40 years old. So we know that it's the same as BC. We see that the people who are injecting drugs are older, that the new people are less likely to begin to inject drugs. So all these things together, and we've done some sensitivity analysis with what I've just shown, but still we think that there is a curve up after 2022.
All right. So
good?
yeah, perfect.
Thank you very much.
Thank you so much, Julie. All right, so we are going to move into our abstract session. We have 3 fantastic abstracts coming up. The first is Kate was hiding in the back, but she's here. So Kate Dunn will be presenting on the perspectives on hepatitis C self-testing among First Nations populations in Ontario.
All right, so I think everyone here knows that I'm Kate Dunn. I'm from Mississauga First Nation, and I work at York University in the School of Nursing. And this project isn't one of my babies. I got nominated to share some of these insights from the team. Jaden was supposed to be presenting, but she's had some health situations come up, so she is at home on Sioux Lookout. But also Tamara, Karen, and Dr. Biondi. It's more their project than mine, but I'm excited to share some of these insights with you. So what is this and how we got here? The World Health Organization has identified that self-testing might be something that might be a relevant concept to consider when we're talking about hepatitis C, both in a global kind of concept, but also in a Canadian context. It's not something that's approved, obviously, so we had to be a little creative in asking about this, because I'm a firm believer in you got to ask before you jump in and do things, right? So what might that look like? What kind of considerations would we need to take into this context from an Indigenous wellness perspective, instead of just jumping in with, you're the problem, here's something we think that's going to fix it, you better do this. So instead, being a lot more reflective. So why did we need this to happen? In conversations with populations across a lot of different places, people have shared that testing always comes with barriers, right? Distance, timing, concerns about privacy, stigma, trust, lots of different barriers. And in the roadmaps, there's been a lot of priorities of how do we look at these barriers, how do we break them down, how can we get creative about this, and self-testing has come up as something there. And how do we align this? And so we came up with a comparative with the HIV, which has self-testing. They have this fabulous app and all kinds of systems in place. So we used that as kind of a, oh, what if? And we went into community with the purpose to better understand what this might feel like from a community perspective. We visited with 15 adults in different settings in 3 different places in Northern Ontario. And of course, I like to take toys for people to play with. So I had some sample test kits, and they held them, played with them, figured out what it would do. It wasn't loaded, obviously. And then we took out my phone and looked at the HIV self-testing app. This is what it would look like if your result came back positive. This is what it would look like. Here's some of the pictures that are on here. Do you see yourself in these pictures? Would you engage with this? Do you trust your phone to have these kinds of results? So really kind of leaning in to this casual conversation in a table setting where these people felt like they were in a trusted space. So all of these conversations happened either at Elevate or at Accessory Zoo, which are urban settings where people feel trust. And it also brought to light that people engage in research opportunities for the hot coffee and donuts. And once they're in a warm setting, this was done last winter, when you're living rough and you come indoors and you have a hot drink in your hand, you either fall asleep because you know you're in a safe space, or you're just so comfortable that you really lean in and enjoy your high, right? So this was very much lived experience on the, people not necessarily sitting in a clinical setting following, a very crisp paper, here's your survey, answer these questions. This was very much lived experience where people's hands were so frostbitten they couldn't, sign the receipt for their honoraria. I had death threats for not giving them an honoraria and was told by the police to hunker down and don't show your face until we get this solved. Like, this is real life. And I think that it is by going into these kinds of settings and sitting, bringing the hot drink, giving them 10 minutes to take a power nap, and then see if they're still, engaged enough to be able to lean in and answer these questions and look at the pictures and give us some insights on, does this make sense for us to even keep pursuing, right? So some of these, the feedback that we got really showed that people want opportunities. They want to have choices. They want to find things like this in places where they feel like they can trust the setting, trust the people, and trust that their engagement is going to be not taken advantage of. People requested that there be teachings involved and supportive care package type things involved, so that it wasn't just, this is the only thing that we're getting out of this interaction. People suggested that maybe these self-test kits could be in places they already frequent, like pharmacies, methadone clinics, but also they thought about the library. They're like, we can go into the library, we can go into City Hall, because we might be going in to pay our fines for something completely unrelated. Nobody knows why we're going in there, which gave some ideas of, wow, we really need to be thinking about, if people are not engaging in self-test screening or any kind of screening because of the judgment that they feel, then how are we really leaning into what people are telling us and considering how we do better at where we're providing these opportunities? And then the messaging is really, really important. People want messages that emphasize curability. They want clear steps. What do I do next? What is this going to lead me to? And who's going to care about this process? They want bold visuals and very little words. In fact, one person told me, if it has eyes on it, I'm going to stop and look at it. If there's no eyes, like even emoji kind of characters with eyes, they would stop and look at it. But if it's all words and just, there's a circle and then there's the words, they don't even stop. They don't even look. It does not catch their attention. They need something to feel like it's humanized and it's there for them. And it needs to really include non-stigmatizing language. And from a First Nation perspective, really leaning into those land-based connections, because that's what builds trust, builds that connection to, this is part of a healing story that I can see myself as being part of. So some of those quotes were that it's not as dangerous as it's stigmatized to be, and that it's not really a death sentence like they make it out to be. A lot of people said that the self-testing process was acceptable. They totally would do it. One person said that they've been using needles since 2017. Why would a tiny little one like that be scary to them? It was the result that was scary to them. So I think that sometimes we focus just on the safe needle, when in actuality, it's that result. Are we framing that result and how we're going to follow up and care about that result is where I think sometimes our focus needs to really shift. Oops, did I forget to advance the slide again? Sorry. And then that self-reporting and linkage to care. Some people said, no, I would rather do the test and find out the result while I was in a doctor's office. But as we know, there are a lot of people who never go to a doctor's office. So obviously, we have to provide options and opportunities for lots of different settings. And I was actually surprised at how many people felt comfortable with getting the result on the phone, like the app, because the HIV self-testing app that we were kind of sampling and running through, they're like, oh yeah, I would be comfortable with that. But it tended to be people who had their phone in hand who were kind of saying that. I realize there's a lot of people who do not have access to a phone. So of course there's limitations. There's limitations with everything. Of course, the participants, we just met with 15, so it's not representative of an entire population or an entire people group. There's going to be different perspectives in different places, partly depending on what work we've done there already, right? Have we built a really good foundation? Then yes, when we try something new, we're probably going to have better success than if we're trying it in some place where we don't have trust built up or good pathways built up. And some of this was hypothetical, like I had a play kit there, and we were using HIV information. So obviously some limitations there as well. So what's next? We really need to prioritize blending lots of options. We really have to go into different settings with a menu, because no matter how we fine-tune one thing and think it's the best thing, it's not the best thing for everyone. And I think we need to really keep that in mind. Finger prick is very easy for a lot of people. People are not afraid of that, and it's something that we probably could be taking more advantage of. People feel comfortable doing that. I think the diabetes awareness has really destigmatized that approach for us, so maybe we should be taking more advantage of it. The real anxiety is not about doing it, but it's about finding out the results. That's where the anxiety is. So leaning into what are we doing better around messaging and framing and really focusing on the curability. And I think that the key part is when we're doing these sorts of engagements is to really listen to what people are saying, how it feels, not just how it looks from our perspective, and then taking these insights to co-create that action step. It can't just be us in our clinical settings making all of these decisions. If we're taking the time to go into community and really listen, then we need to then take those steps and insights forward into how we co-design the next steps. So thanks for the team who did all the work on the project.
Thanks, Kate. A little bit of time left, so if you don't mind, the Q&A is always the best.
I wouldn't want you to escape without a question, Kate. No, awesome. I think this is really important work. And I guess what I was wondering is, did you specifically ask them in the in-depth interviews, would you prefer a self-test to a test administered at a clinic? And the reason I ask that is, look, I think WHO is kind of just taken their HIV self-testing and tried to say, oh, well, it's going to work for Hep C. And I think we need more work like this to actually find out from people whether they actually want it. We did a study where we gave people the options of the 1-minute INSTI self-test, 1-minute INSTI staff collected, the BioLine 5 minutes dry blood spot gene expert, and 80% with like a visual diagram and explain people the different options, and 80% chose that they wanted the quickest 1-minute test, but they wanted it from a healthcare provider who was sitting right there. They're like, oh, well, no, just stick my finger. I don't want to go in. But I thought maybe people would be like, no, I just kind of want to go sort it out on myself. But that's people that are attending a clinic. So I think important, like you made the point, that doesn't necessarily, not everybody's going to a clinic. But I'm just curious if you did ask that question and whether there was any perspectives of that. Because I think this is a really important question that we need to sort out, because I don't think we know whether people want Hep C self-testing.
Yeah, some do, and some would use it. I mean, I kind of, the Catalyst project that I just wrapped up this summer, doing 50 interviews with First Nations people in Northern Ontario, and kind of weaving it in based on, the vibes and how comfortable some of these people were asking, well, what are your barriers? What do you think are the barriers for screening? Because I would say 98% of the people I talked to in the Catalyst interviews I just did aren't aware of Hep C, what it means, who could have it, why they should care. So we have massive work to do around awareness. And I think part of that awareness is creating options. There are people that are way more comfortable picking up a care package or well, look, it's all in one little bag. Here's the very clear directions. Yes, I'm in control of my health. I feel comfortable with this. I know what to do next. We need to create these things for those people. Is that everyone? Absolutely not. Yeah.
Sorry, I may have missed it, but I don't think I quite understood the mechanics of how this self-testing works. So you mentioned finger pricks. So is it a PLCT kit or is it a DBS? And do
It's not
they
something
actually
that's
get
currently,
the test and take it home?
Yeah. I didn't write the whole proposal. I was asked to come in and do these 15 interviews, so I'm not the expert on the whole angle here. But it's spinning off what's available for HIV, which used to be widely available as a self-testing access. There's limitations on it now. And it's a quick point of care thing that's step by step. I think building off, we all learned how to do COVID tests, so why can't we all learn how to do some of these other self-tests? And I would say overall, people are very game to learn. But I think we just have to be careful to not make the assumption that everyone will be able to figure out. It's kind of complicated, and there's blood involved, and there's needles involved, and the terrifying part for a lot of people is finding out, oh, this is positive. Oh, crap, now what? Because in a lot of communities still, it feels like a death sentence. So we have to be really careful around that.
So each person was given a
No,
personal
I just had a
interview.
sample.
How
We
did-
didn't do any testing.
Uh-huh.
They met we had coffee, I showed a sample of, hey, it would look like this. What do you think? Would you feel comfortable using this? Yeah.
Fantastic. We will, sorry, Mia, your hand? So it was, just so everyone in the room can hear, Mia was saying that they were using or proposing the OraQuick finger prick test to everybody, and at that time, the INSTI was not approved. Thanks so much, Kate. I think Kate's talk is a beautiful segue to Liv's talk, titled The Acceptability of Dried Blood Spot Testing for Hep C and Other Bloodborne and Sexually Transmitted Infections among People Incarcerated in Quebec Provincial Prisons.
Thank you everyone for sticking around to the end. I'm going to be presenting what we learned about dried blood spot testing during interviews with men incarcerated in Quebec prisons and what that might mean for STBBI prevention in carceral settings. So people in prison experience a disproportionate burden of hepatitis C, HIV, and other STBBIs compared to in the community. And many of these infections are undiagnosed. So there's a real need to streamline testing practices to improve diagnosis and linkage to care. Dried blood spot testing uses a lancet to prick the patient's finger, and then the drops of blood are put on a filter paper. So it's a low-burden method that's well-suited to carceral settings, which are often settings where there's low time and resources are limited. It has some advantages, so you can test for multiple infections using the same samples. It doesn't require a clinician to collect the sample. It's got high sensitivity and specificity, and relative to point-of-care testing, it's cheaper. It also has some disadvantages. So from a laboratory perspective, it's slower and more labor-intensive compared to point-of-care testing. And currently in Canada, it's only approved as a diagnostic method in 2 provinces, with a further 2 provinces undergoing approval. So PIC3 is a study run by Nadine that aims to estimate the prevalence of STBBIs in 7 Quebec provincial prisons using dried blood spot testing, so specifically hepatitis C, HIV, hepatitis B, and syphilis. And provincial prisons are those which hold people who are either awaiting sentencing or are sentences for 2 years or less, and the median time the median length of stay in these prisons is 30 days, so it's quite a rapid turnover. And participants were offered the choice between self and assisted collection of the sample. This was a qualitative sub-study of the PIC3 study where we aimed to understand the acceptability of dried blood spot testing as a screening method for hepatitis C and other STBBIs. So we were based at Saint Jerome, and we approached people when their results of the DBS test were given to them to ask if they wanted to participate in a further qualitative interview. We interviewed people until we reached saturation, and we purposely sampled people to ensure variation in characteristics that we had determined a priori might be related to acceptability of dried blood spot testing. So injecting drug use history, bloodborne virus status, race or ethnicity, and whether they chose self or assisted collection. Interviews were conducted in English or French, and participants received $10 into their canteen account for participating. So we used the theoretical framework of acceptability to inform the interview guide and coding, and this was used to explore how participants felt about, understood, and engaged with dried blood spot testing. It comprises 7 domains, which I'll go through one by one in the results, and we had 2 researchers independently code the interviews until concordance was reached. So just quickly, the patient demographics, all 15 identified as men. The median age was 35. 1 in 3 had a history of injecting drug use. 2 out of the 15 self-collected their sample. 1 in 5 were Indigenous, and about 1 in 4 tested positive for at least one of the STBBIs that we tested for. So beginning with affective attitude, this considers the individual's overall emotional response and feelings towards the intervention. And participants consistently express comfort and describe DBS testing as easy and efficient. And a primary driver of this positive affective attitude was the comparison between the finger prick and traditional venipuncture. So participant 4 here is describing that it's much more accessible than a traditional blood test. Another factor that influenced this was the perceived efficiency of multiplex testing. So participant 2 here is describing that it's more practical than undergoing separate tests for the individual diseases. Echoing what Kate just said before, the primary emotional response relating to the test actually centered on the implications of the results rather than the physical experience of the test itself. So the main source of anxiety for several participants was a positive result, as demonstrated by participant 1 here. This concern often outweighed the finger prick. This concern often outweighed emotions towards the finger prick itself, which was generally viewed as a minor and manageable event. Conversely, some expressed a sense of reassurance in knowing their disease status either way. So participant 13 here is describing this. And this was viewed by some as particularly important in the prison setting, which was viewed as a place with distinct risks for disease transmission. So burden refers to the perceived amount of physical or cognitive effort required to participate in the testing process. And in general, the perceived burden of the finger prick was low, as described very succinctly by participant 12. Again, there were comparisons made to venipuncture, with participant 6 describing DBS as a lower burden in terms of bruising compared to previous blood tests that he'd had. We considered opportunity costs to be the extent to which personal or institutional activities like work or programs or values like confidentiality and privacy had to be sacrificed to engage in the intervention. And in general, prison was viewed as an opportune time for testing with few competing priorities. Participant 11 here contrasts the cost in terms of time and effort in the community versus the prison, saying that you must make an appointment when you're outside, so I found it practical to just take the time to get screened in prison. Others spoke hypothetically about needing to give up work in prison, with participant 5 saying he would sacrifice his shift to be tested, suggesting that the benefits of screening outweighed those of his work in that situation. These data suggest that for many, knowing their disease status was a primary motivator of being tested that outweighed the personal costs of participation. So self-efficacy refers to the individual's confidence in performing the behaviour required for the intervention. And sort of in contrast to what Kate just presented, in the PIC3 study, we were surprised at how few people chose to collect their own sample, given the existing research that generally suggests that self-collection facilitates higher uptake. And so this quote at the top here from participant 2 highlights 2 of the barriers described by participants. Firstly, a fear that self-administration would lead to hesitation and therefore more pain. And secondly, that the collection of the sample is a specialised task that's better performed by a researcher or someone with specialised training. Participant 1 here, who had a history of injection drug use, also reported that he chose assisted collection due to the fear of being triggered by using the lancet. So ethicality considers the broader moral and systemic implications of how dry blood spot testing is delivered in carceral settings. And some participants described being given the choice between self and assisted collection as respectful of their individual agency, something that's often removed in the prison setting. Participant 4 describes the discretion of DBS testing as an ethical facilitator, suggesting it could allow for more confidentiality in prison. There was also a strong sense that regular STBBI screening should be standard in prison, with participant 4 asserting that everyone should do it when they're inside. And I'll just pause here. So those were the first 5 of the 7 domains, and the last 2, which is perceived effectiveness and intervention coherence, the results were very similar across the board. So all participants reported that they understood how the intervention worked and that they believed that it told them whether or not that they had an infection. So I've just left out quotes for that. But during analyses of interviews, the role of the provider emerged as an inductive theme, suggesting that the communication and perceived care during dry blood spot testing was a mediator of acceptability. So participant 1 here is comparing his positive experience during the study and compares it to previous negative experiences with prison health. And participant 2 is describing his trust in the perceived effectiveness of the test because he has fewer doubts because it was delivered by a university, while prison healthcare doesn't care to know. So these results suggest that the level of engagement by the provider can either mitigate or exacerbate existing power imbalances in the carceral setting, and that who and how the test is delivered is as important in terms of acceptability as the test itself. So some strengths and limitations of this study, we included a range of diverse perspectives reflecting important factors that were associated with acceptability of dry blood spot testing. And we've also conducted a further 15 interviews with women, and preliminary analyses of these indicate that there's some concordance between these groups. A major limitation of this work is that the people we interviewed were still in prison when we disclosed their results to them. And so the dry blood spot testing can take about 2 weeks to get the results back, and it's likely that the people who were still around to have their results disclosed to them have a more positive perspective on the value of the test compared to people who were lost to follow-up and never got their results. And potentially social desirability bias within these interviews. So overall, these findings offer an important insight into the potential role for DBS in improving STBBI healthcare in prison settings, and there were some clear benefits expressed by participants, including low perceived burden, a preference for finger prick testing over venipuncture, and the value of testing for multiple infections with one test. Prison was also seen as a good time for testing, with participants describing low opportunity cost in terms of what they needed to give up for the testing, but also describing the benefit of screening to the broader prison community in terms of reduced disease transmission. The findings also emphasize some challenges. Although it's often described as a simple and accessible test, very few participants wanted to self-administer the test. As I said, the turnaround time was anxiety-inducing for some, and as I noted before, meant that some people never received their results, despite a lot of attempts to get in contact with them after they were released. And finally, and importantly, the acceptability of the test was mediated by the provider, highlighting the importance of building trust and rapport when undertaking diagnostic screening in prisons. And we're planning that this work will be presented in tandem with the validation study of DBS to the INSPQ, in hoping that it will lead to validation of this method as a diagnostic method in Quebec.
Excellent.
Oh, acknowledgements. Also some acknowledgements. No, that's okay.
All right, thanks so much, Liv. Any questions from the floor?
Great talk, Olivia. Thank you so much.
That's okay.
I think perfect follow-up to Kate's talk. And I just wanted to mention, obviously, like self-testing and having it Health Canada approved, it's a bigger lift, right? The manufacturer has to go to Health Canada with the data, and as you all know, and everybody in this room knows, DBS is not approved for anything by Health Canada, so it's like a bit of a different scenario. I really appreciated your last point, and it could be a question for you or Nadine or anyone else in the room. Did the Prov Lab ask you for the validation study? Do you think if you give it to them, they're gonna go for it? Like, we have this national lab approach, which works for some communities. We have no indication in Ontario that this is ever going to be accessible to us.
Yep.
So yeah, just a question.
Yeah, so when we were designing this study, I worked with some people at the ENSPQ, recognizing that it was not validated in Quebec, and asked them, what do we need to do to contribute to the validation of DBS in Quebec? And so, in part, the sub-study about acceptability was not discussed at that time. It was simply that we agreed that every positive DBS test was going to be confirmed in prison by phlebotomy or venipuncture, and that they were going to use that data. There's 1,350 people that will be recruited, so quite a large sample. And I can't hold anyone to their word, but I presented this work to the northern team in Quebec, and they had also mentioned that the INSPQ, and there's Karine Blouin here who can maybe comment herself, but that INSPQ and LSPQ were very much looking forward to the data to drive the validation efforts, the diagnostic work. DBS is a diagnostic tool.
Can I ask one follow-up question? So that's validation. And then what about the cost implications? Like, is there provincial buy-in on around that?
We didn't. That was not ever discussed, to be honest. I think the issue is that they didn't have many DBS tests in Quebec that had been further validated, i.e. positive is positive, negative is negative, and so they wanted that as a first step, despite the very high sensitivity and specificities. Yeah.
Thanks for the presentation. Really nice data. I have two questions. One sort of as a follow-up to Mia's question, but when you talked about the anxiety that people had, did you ask them what they were nervous about? Like, was it any positive result, or was it focused on specific infections that you were testing for?
It wasn't. It was any infections. Yeah.
Okay, that's interesting. Because I guess I wondered, like, especially where you might have the opportunity to potentially give some answers with a point of care test and use this as a, like, for example, with Hep C, you could do a point of care antibody test and then this for RNA testing. And I guess just in question about the validation, they only wanted the positives. It's the negatives that they really need to confirm.
Yeah, I know. They were only interested in the positives, and I can't explain that. It was already. It's a huge feat, even linking people in healthcare to do the validation of the positive tests, but they were only interested in positive.
They thought there were going to be false positives?
They thought there were going to be false positives.
Okay, no comment.
Yeah. No. You're all done. Good job. And last but certainly not least, Sofia Bartlett will be presenting on the increasing burden of syphilis among people with hepatitis C in British Columbia.
Oh, yay, we get the notes. Okay. I'm just chuffed to have an Australian accent to lead in before me. It's just such a novelty. So thank you, Liv. I'd like to acknowledge the title and the rights of the First Nations, Métis and Inuit people who've cared for and nurtured the lands, air and water around us for all time, including the Mississaugas of the Credit, Anishinaabe, Chippewa, Haudenosaunee, and Wendat, whose territory we're gathered on today. And I am a white occupier living and working on the traditional unceded territory of the Musqueam, Squamish, and the Tsleil-Waututh, on whose territory the BC Centre for Disease Control is located. These are my disclosures. Also have this disclaimer to offer. And I'd like to start by addressing maybe the elephant in the room about why I'm talking about syphilis at a hepatitis C symposium. I think we talk a lot about the problems, but the reality is that, even though Hep C testing and treatment coverage could be better, there's actually a decent platform. We have infrastructure. We've been working on this for quite a while. And thinking about how we can leverage that to address this growing syphilis outbreak, I think is a smart way to increase the value of our hepatitis C elimination efforts. I'm also hearing anecdotally from providers that they're finding it more and more challenging to manage engagement and long-term follow-up for people impacted by hepatitis C who are also experiencing neurocognitive impact from surviving multiple toxic drug poisoning events, and then on top of that, neurosyphilis. So as if it wasn't already hard enough, it's becoming harder and harder. So I think there's also a selfish element here in that if we don't start thinking about syphilis, it might actually further undermine our efforts to provide hepatitis C treatment to this already marginalized population. So I think we've already made progress towards hepatitis C elimination in Canada and in British Columbia. Are we on track? I don't know, probably not, but we have made progress. But we've also seen this resurgence of syphilis at the same time. So comparing 2018 to 2023, for infectious syphilis in Canada, we had an increase of 90%. And for infectious syphilis in BC, we saw an increase of 212%. For 122% for infectious syphilis overall in BC. For congenital syphilis in Canada, that was a 212% increase. And in BC, we are not able to quantify that because we went from 0 to 21 cases for 2023. And what we're seeing in BC, and particularly in Western Canada and the prairies as a whole, is this really significant epidemiological shift. Historically, we saw infectious syphilis concentrated among gay, bisexual, and other men who have sex with men. But by 2023, 68% of infectious syphilis cases reported in British Columbia were among heterosexual men and women. And among that population in British Columbia, infectious syphilis is associated with substance use, housing instability, street involvement, transactional sex, and mental illness. We have this BC Syphilis Action Plan, which was launched in response to the outbreak of syphilis that was declared in July 2019. And one of the key goals of that was to increase syphilis screening among people who use substances. Despite that, we still see syphilis screening coverage in substance use care settings suboptimal. If you think that Hep C screening in substance use settings is poor, let me tell you, it's even worse for syphilis. And so we really need more scalable strategies to increase the coverage of syphilis screening in these settings. But this also begs the question, are we going to be seeing this emerging syndemic or overlap of syphilis and hepatitis C among people who use drugs? Because those factors that I just mentioned before that we're seeing associated with syphilis, that's the exact same factors that we see associated with Hep C. There's shared transmission networks, shared structural drivers, but then we also have the same population who's already engaged in Hep C testing. So this kind of seems like a pretty obvious opportunity. So, the question going into this analysis was, how can we maximize the value of hepatitis C testing encounters, centralize lab infrastructure and testing touchpoints among people who use drugs? And our aim was to assess from 2018 to 2023 the trends in syphilis EIA screening, so syphilis antibody screening, and positivity among people who've been tested for hepatitis C antibodies in British Columbia. So we used data from the BC CDC Public Health Lab to identify people in BC who were tested for hepatitis C antibodies between 2018 and 2023. So this is province-wide data. BC CDC Public Health Lab performs more than 95% of all hepatitis C antibody testing in the province, and it's 100% for positive antibody tests. And they do 100% of all syphilis antibody screening. So using that data, we were able to then determine if people who'd been tested for hepatitis C antibodies also received a syphilis antibody test on the same day as their index hepatitis C test, and then how many people screened positive or negative for each of the combinations of hepatitis C and syphilis. And then we've done descriptive analyses to describe the number of people who were tested for each test by year and the combination of test results among those tested. So we had a total of almost 2 million hepatitis C antibody tests performed in British Columbia between 2018 and 2023. Among those, about 96% are hepatitis C antibody negative and about 4% hepatitis C antibody positive. And then when we look just among the antibody, so hepatitis C negative tests, which is almost 1.9 million, we then went and described among those people how many had a syphilis antibody test performed on the same day that antibody, the hepatitis C index, was performed. And as you can see, there's really quite a substantial number of people who are having, a substantial number and proportion who are having the syphilis EIA performed on the same day as the hepatitis C antibody test. And the test positivity for syphilis among that group who have been tested is sort of trending up over time. So the syphilis EIA positivity was 2% in 2018, and it grew to 4% by 2023. And the number of people who screened hepatitis hepatitis C negative, who were also screened for syphilis on the same day, actually increased by 24% from 2018 to 2023. When we look at the hepatitis C antibody positive testers, we were seeing a completely different pattern. So among them, the proportion who were testing hepatitis C antibody positive for the first time overall was 11%. So I think it's important to note that the majority of these hepatitis C antibody positive tests, these people are already diagnosed. They know that they have hep C. And we see this really commonly, just repeatedly being antibody tested again and again. And that typically indicates that these people are people who use substances and they're engaged in ongoing care. And unfortunately, substance use providers are still ordering the antibody test. And among those who were screened, among those who were hepatitis C antibody positive, and then they were screened for syphilis on the same day, the EIA positivity was 10% in 2018, and it grew to 16% by 2023. So that's a 170% increase. And despite increasing syphilis EIA positivity, the number of hepatitis C antibody positive testers who were screened for syphilis on the same day declined by 15% from 2018 to 2023. And that's partly because we're seeing the number of hepatitis C antibody positive tests come down. But unfortunately, despite our wonderful syphilis action plan, we're still not doing more syphilis testing in this population. It's stayed relatively stable. So overall, among people who screened hepatitis C antibody negative, 50% of those were screened for syphilis on the same day, and 3% were positive on the syphilis EIA. And then among people who screened hepatitis C antibody positive, 29% of them screened for syphilis on the same day, and 9% of them were EIA positive. Okay, take-home messages. Good news, hepatitis C transmission appears to be declining in British Columbia. We saw this declining hepatitis C antibody positivity between 2018 and 2023, and you saw it was a pretty significant trend down. This is, I think, encouraging progress towards elimination because we're actually doing, I haven't included the denominator, but we're testing more people for hepatitis C than we have in any previous year, and more hepatitis C tests done in 2023 than any year previously. So we had a good recovery after COVID. The same-day syphilis EIA testing among anti-hepatitis C positive specimens increased proportionally, 23% up to 37%, but the absolute number declined in that period. Syphilis EIA positivity among people who are hepatitis C antibody positive has risen substantially during the period that we looked at, which is a signal that there is a growing overlap between these epidemics, and this sort of syndemic effect appears to be happening. We also think that there is, oh, what did I just do? So, I'll go back into the, oops.
No.
Bear with me. This is like a rapid fire recap of everything.
Sure, that's way forward.
If I didn't make you dizzy already. Lucky I didn't have too many animations. Okay. Syphilis EIA positive, where did I get up to? Oh, right. So if, for example, so we've got these missed opportunities that exist. The same-day syphilis testing increased proportionally, but absolute testing declined. A comparator for this sort of group, we've got data from a, what did I describe it as? A low barrier clinic in Vancouver that was collected in 2011. So this is people accessing substance use care after they've presented to St. Paul's Hospital after an overdose. 111 of them were screened, so it was 49% uptake. And it was 3.6% of those had infectious syphilis. And if we compare that to what we've seen in this analysis, we had 16% syphilis EIA positivity. That's not directly comparable because that's comparing infectious syphilis to ever had syphilis. But it does sort of suggest that if, for example, we were to implement reflex testing at the lab level, where the specimen's already been collected, if somebody tests hepatitis C antibody positive, the lab just adds the syphilis test on automatically, that we could potentially be identifying many more hepatitis C cases, syphilis cases, without providers having to do anything. It's a sort of an automatic add-on. And we would estimate up to maybe 540 additional positive syphilis cases annually. And the overall number of additional tests that the lab would have to do is actually quite low. So it would be probably manageable within their current infrastructure. But also, I think, suggests providers to start looking at this as well. So, as I mentioned, this analysis captures syphilis EIA positivity, which is obviously only exposure. It's not infectious or untreated cases. When we initially did this analysis, the data weren't linked, but they are linked now. So we can identify among those who test syphilis EIA positive, did they actually have infectious syphilis or were they untreated? And so we need to do more analysis there to estimate the impact on active disease detection, as well as to describe who are those people who have both hepatitis C and syphilis infection, and looking at the sort of change in trends over time. So, is this skewed towards younger people? What is the sort of sex gender distribution, other sociodemographic factors? Also looking at exploring what lab-based reflex for syphilis EIA on anti-hepatitis C or hepatitis C antibody-positive specimens would look like. In the BC-CDC Prov Lab, we actually already do this for first-time hepatitis C positive testers. If they're what they determine as seroconverter, they add on a HIV test. So we already have a precedent for this with HIV. This is just another reflex. And I think the other part of this is to look at what are the testing patterns happening in other parts of Canada where we're seeing this change in syphilis transmission. And, I think providers who are offering hepatitis C testing to people who are using substances really should be thinking, if they're not already doing that, to universally offer syphilis screening, and sort of thinking about that as an additional case finding strategy. I'd like to acknowledge the people whose data was represented in these analyses, as well as the rest of the teams and funders who've contributed to this. Thank you.
Thanks, Sophia. We are at time, but if someone has a burning question, I'll let it pass. Maybe I have a question.
Okay.
Why do you stop at syphilis? Why would you not also look at data for chlamydia and gonorrhea?
Because it wasn't linked yet, but it is now.
Okay.
Yes. Yes, next step. I think that's actually like the full syndemic characterization.
Absolutely.
Yeah, and we also want to look at the reverse, among people who are tested for syphilis, how many get the Hep C? Because I think that's also part of the equation.
Right.
Thank you.
Yeah, thank you. All right, so big round of applause for everyone. Thanks so much for staying. And just a reminder that there is the poster session going on now, as well as the opening reception. So there's drinks, alcohol, and food waiting for you at the concourse level.